All right, let's keep going. Well, if you take care of patients with COPD, it won't be long before one of them comes in with this. It's an exacerbation. It means their normally well-controlled disease is now off the rails. Gold describes it as an acute event, and you can see what's in these quotation marks. But for you, it means we got to change their medication regimen. And so, look at my question for you. What choices below may contribute to a COPD exacerbation or worsening of airway function? Like, what might cause an exacerbation? Select all that apply. Number 1, infection. Oh, yeah. 8 out of 10 times when a patient with COPD has an exacerbation, 8 out of 10 times they're infected. What about air pollution? Oh, yeah. Right? Air quality, when it drops, you'll see it. Time of year. Circle that one too. What time of year, Amelie? It's often fall and it's often spring. All right? Ring a bell. Wait for your COPDers to come in at that time. Look at number 4. It says beta blocker use. Hey, wait a minute. What's that about, Amelie? A beta blocker? Yeah. Even a cardioselective one. Because we don't want to block the beta receptors in people with lower airway disease. We want to stimulate them. You got it? So sometimes you can put a patient with COPD on a beta blocker and they have a lot of difficulty breathing. So that's a possibility. Circle number 4. Could metformin cause an exacerbation? No, that's a trick. Look at number 6, atorvastatin. That's a trick too. Don't get tricked. So listen, how about number 1, number 2, number 3, and number 4? All right? Those all can contribute to an exacerbation of COPD, but not metformin is certainly not a statin. Everybody got it? I'm not feeling the love in this room about COPD. All right, so how are you going to manage this exacerbation? The first thing you must do is figure out why they're having an exacerbation. Because if they're infected, you'll probably give them an antibiotic. If it's because they live in Los Angeles and the smog level is high and the air quality is very low, you got to keep them inside, right? So you got to address whatever the underlying cause of the exacerbation is. Well, I'm sure you've taken care of patients with COPD in some setting before, whether it's a hospital or in a clinic, and I hope it's both. And one thing you're going to realize when you take care of patients with COPD is that they're complex patients because you don't just have COPD. When you have COPD, meaning your lungs are wrecked, it's going to soon cause trouble in the heart because the heart and lungs work so closely together that if you got trouble in one place, you will soon have trouble in the other one. Well, when we think about the comorbidities of COPD patients, you know you're going to have cardiovascular disease. You're going to have arrhythmias, tachyarrhythmias. Have you ever seen a COPD or an atrial fib with a rapid ventricular response? Every day of the week. So my point in being is that when they have COPD, you are going to be managing some cardiovascular problems as well. Guess what else? We often see metabolic syndrome or frank diabetes. Now, that creates a problem, doesn't it? Because when we treat an exacerbation, we usually give a drug class called steroids. What does that do to somebody's blood sugar? Drives it way up. Hold on to that thought. Why do we commonly see osteoporosis in a COPD? Okay, I'm hearing steroids. Yeah, maybe. Is it because of smoking? Oh, I forgot about that risk factor, Amelie. Yeah. So you commonly see bone issues in these patients. If you can't breathe, and you know it's just gotten worse, is it a happy day for you? No. We see depression and anxiety. I don't know if I'm going to get my next breath. You think you're going to feel good about it? No. So we see mood disorders in these patients. And then finally, look at the last bullet. Lung cancer. COPD is not a happy disease. It's not. So, lots of comorbidities associated with it. And I got to make sure I put this in your brain. So listen, I told you I was going to make sure you knew enough pharmacology. Let's talk about the effects of the medications we use to manage our patients who have COPD. The first medication up here is a beta agonist. Give me an example. Albuterol, salmeterol. The location is in the airways. What's the effect on the airways when you use a beta agonist? Bronchodilation. Write that in the blank. Look at the next one, a beta agonist. If you affect the beta receptors in the heart, what's the effect in the heart? Tachycardia, write that in the blank. The beta agonists, the sympathetic nervous system. You affect the sympathetic nervous system when you give albuterol. Give me an example of the effect. Tremors, their hands shake. Have you ever watched them try to get their inhaler to their mouth? Sometimes their hands are shaking so much from, all right, there you go. So tremor. Look at the next medication, an anticholinergic, like one of the tropiums. Its effect is in the airways. What's the effect? Prevents bronchoconstriction. Write that down. What's the effect of an anticholinergic in the ileum? Because it sure is affected there. Things don't move like they're supposed to move. What's the effect? Constipation. Now, if you can't breathe and you're constipated, I promise you won't have a happy day. All right, what about an anticholinergic in the eye, specifically the iris? You know what happens? Intraocular pressure goes up. Oh, so that's why we are very careful with use of anticholinergics in people with glaucoma? Yeah, you're so smart now. There you go. What about the effect of an anticholinergic on the bladder? What does it cause? Urinary retention. So if you're a little old man with BPH and you already have urinary retention, you think Spiriva's going to be your friend? It'll probably make your problems worse. And then finally, look at the last one, an oral steroid's effect in the airways. What's the effect? It reduces inflammation. So do you see why having COPD is not a happy disease? Because the meds that you take help you breathe better, but there are all these side effects that most people just don't like. Everybody got it? Let's keep moving. Here's your next patient. A 60-year-old female with a 30-pack year smoking history. Stop. What does that mean? 30-pack year. Well, listen, it's calculated, and you need to calculate it too. And even if you're not a math whiz, this one's easy. If you smoked a pack a day for 30 years, it's 30 times 1, 30-pack years. If you smoke 2 packs a day for 15 years, 15 times 2 is 30, a 30-pack year history. So we don't need to know really how many years she's been smoking. She's got a 30-pack year history. What does that mean? She didn't start yesterday. The significance of 30-pack years is that no matter how wonderful your genes are, once you hit a 30-pack year history, you have COPD. There's no way your lungs will last. 30-pack year history, you got COPD. So that's what I'm telling you about this patient up here. They are in your clinic for an initial visit. How should they be screened for lung cancer? Well, we know that they get a low-dose CT of the chest. Let's talk about it. The low-dose CT of the chest has been recommended for at least a couple of years now by the United States Preventive Services Task Force, the tightwads. Now, these people are recommending it annually. Annually, that means every year they want them to get a low-dose CT if they're a current smoker and between the ages of 55 and 80 with a 30-pack year history. We also want you to screen them annually between the ages of 55 and 80 if they quit smoking within the last 15 years. So we want you to screen people. Now, let me just kind of toss it out. When you screen people for lung cancer, is that primary, secondary, or tertiary prevention? It's early detection. Which one is that? Secondary, right? Secondary. Primary means we're preventing you from getting it. Secondary means early detection. Tertiary means you already got it. Our intervention will keep it from progressing. So which one is this? Secondary, right? It's early detection. That's the purpose of it. All right, so take a look. What symptoms might be suspicious for lung cancer in this 60-year-old female smoker? And it's to select all that apply. Well, number one says weight loss. Circle it. Fatigue. Circle it. Lung cancer, as far as I know, doesn't make you have insomnia. Doesn't make you have elevated liver enzymes. Hemoptysis, I know I'm circling that one. Fever, can't help but circle that one. Number 7, no, not increased appetite. But what might you expect to find on exam? What about a supraclavicular node? Oh yeah, circle number 8. So I think I'd circle 1, 2, 5, 6, and 8. Everybody got it? All right, let's keep going. Have y'all seen a supraclavicular node? They're not common. The easiest way to identify a node is not by palpation. Keep palpating. But when a patient has a lot of tissue, you might miss a node that's buried in all that tissue. The best way to identify a node is to see it. And the way you do that is to make the skin over the area of the chain, that chain of nodes, make the skin over that area taut. So if you want to see the supraclaviculars, the one above the clavicles, you got to put the patient in hyperextension and get them to turn their head. And those nodes will pop out if they're there. You see that supraclavicular node? Here's my term. That bodes ill, right? That's not a good one to find. Why? Because it's associated with a high rate of malignancy. So listen, don't memorize what malignancy, if it's on the right, or what malignancy on the left. Don't memorize that. When you find a supraclavicular node, excuse me, I'll be right back because I'm going to see, go look it up, all right? Not a happy day in your clinic. And so here's our last section, and it's asthma. And oh man, the world of asthma is about to be turned upside down and on its head. Not on your exam, thankfully, but it's coming really fast. As soon as they have time to change the guidelines, we've got brand new changes. So let's talk about what's on your exam and what you're going to do right now in your clinical practice until this changes. You're going to follow the expert panel report. It's given to us by the National Heart, Lung, and Blood Institute, and so here it is from NIH. When you suspect that a patient has asthma, what might make you suspect it is that they have cough, because when lung tissue becomes irritated, produces mucus and a cough. It's just what lung tissue does. What about people who wheeze? What about an adult who tells you, I'm having chest tightness. I'm not short of breath, but some days I feel like I have to use a little extra effort to take a breath. When an adult or a patient tells you that, you always got to be thinking about asthma, or at least it's part of your differential diagnosis. So the what of asthma is what symptoms. We just talked about them. The when. When do you have these symptoms? That's characteristic. When a patient has asthma and they get a viral upper respiratory infection, like a bad cold, you ought to hear their cough. Right? They have a terrible cough. It triggers inflammation in lower airways. That's typical. But you know what else is typical of people with asthma? They have symptoms at nighttime. They have symptoms at nighttime. What's another thing that's typical of a patient with asthma? You know what they'll tell you? Oh man, every time the fall or spring comes, Amelie, fall or spring. The symptoms in a patient with asthma are often predictable. They know when they're going to have these symptoms, like a bad cough or wheezing or chest tightness. So that's the when. And then on your exam, what else might you find in this patient with asthma? You know what you often find? 2 other atopic diseases. Asthma is an atopic disease. So is allergic rhinitis, and so is eczema, exactly. And those 3 little thieves usually run together. So patients with asthma often have two or all three of them. And so you don't want to write asthma on somebody's chart unless that's what they've got. So look at my question. What's most useful to a clinician in making a correct diagnosis of asthma? Well, it's not a chest x-ray. Spirometry, right? Yeah, it's spirometry, circle number 2. Number 3 says peak flow monitoring. We use that to help the patient make a decision about when to use their whatever inhaler or whatever drug we're going to give them. But it's a spirometry is the one that helps us make that diagnosis. And so look at the question. It says, now that you did spirometry, what would you expect to find? What we expect to find is reversible airway obstruction. Reversible airway obstruction. So we give them a SABA like albuterol. We get a measurement before and after the SABA. And what we expect to find numerically, because this is an objective measure, is a 12% or more improvement from their baseline. If making their airways open up helps them breathe better, and they have all the symptoms and nothing else can explain their symptoms, pretty good chance that they've got asthma. So it's reversible airway obstruction. All right. You have a chart in your book that I've sliced up. If I had tried to put the chart in your book on this slide, you would be dizzy, and it's too early in the day to have dizziness. So I sliced it up for you, and we're going to talk about the two different types of asthma. The first type of asthma is one that you're not going to see a whole lot of. It's called intermittent asthma. These are people who have, listen to it, symptoms 2 or fewer times a week. 2 or fewer times a week they have symptoms. If that's who your patient is, they have intermittent asthma, and once you know what kind of asthma they have, you know what drug to give them. All right, 2 or fewer times a week, intermittent asthma. But the vast majority of you people who have asthma will have persistent asthma. That means these patients have symptoms more than twice a week. And if you have persistent asthma, then we're going to give you a certain drug. So let me show you how it comes out. Right now, on your exam and in your clinical practice, this is the way you're going to practice. But I am telling you that the guidelines are going to change, and as soon as they can get them changed, and they can get a different indication from the FDA, you're going to see a major overhaul in these guidelines. So this is what you will use right now in your clinic and right now in your exam. When a patient has intermittent asthma, we're going to use a SABA, a short-acting beta agonist like albuterol. Good job. When a patient has persistent asthma, meaning they have symptoms more than twice a week, our best data says put them on an ICS, an inhaled corticosteroid. An inhaled corticosteroid. Now, why do we do that? We do that because asthma is a disease of inflammation. There's widespread inflammation in the lungs. And when people have widespread inflammation, we want a steroid in there. And with a patient with asthma, it really helps them. So we use inhaled corticosteroids. We typically start off in a low dose. Then we increase it if it didn't help them. If that didn't help either, we add a LABA. So I think you have a good idea about how we manage these patients. Now here's the giant change that's coming. We've got 12 years of data now that say, listen, you wouldn't believe all the side effects of the SABAs. We don't think you should use them very much anymore. In fact, when one of your patients has an asthma exacerbation, you know what we want you to have them do? Take an extra puff of their inhaled steroid. Really? Fewer side effects, better outcomes. That's going to be in your new guidelines. So it's coming. I'm just telling you, big changes are coming. All right? But for right now, this is the way you're going to answer those questions.